Hi, this is Greg Michaud for the AFibProfessional.org Cardiosource website clinical community, and I'm pleased to have Elaine Heilich from Boston University to discuss updates on rivaroxaban and dabigatran. Elaine?
Hello, Greg. Well, I think the first thing I would like to emphasize is that we have many choices available now with the recent approval of apixaban, and clearly exciting news coming from the FDA that when they rigorously looked at multiple different databases, that it appears that the safety of dabigatran in the community is actually very similar to the trials, which I think there was concern about some of these earlier reports, but clearly the rigor in doing a well-designed look has reassured physicians and patients. Other, I think, important news and an update is the finding that now that rivaroxaban is able to be used for venous thromboembolism, which is an important, often seen together with atrial fibrillation. These are common entities in older patients. Important for physicians to remember that with the PE and DVT indication that this medication needs to be used 15 milligrams twice a day for the first 3 weeks. That's key. And then the patient can be transitioned to 20 milligrams once a day. So definitely a little bit of a departure from our atrial fibrillation patients, but I do think that that's an important step forward for the novel anticoagulants. I'm often asked, would patients, would you switch? What about the individuals that have well-controlled warfarin? And, I can understand physicians and patients a little bit of reluctance if you've had impeccable control with warfarin. Those individuals probably, and I think it's been shown, have low event rates, so that I'm not convinced that we need to be aggressively going after those individuals. However, I would emphasize that all of these agents have been remarkable in their ability to reduce intracranial hemorrhage. They've trended toward reduced mortality, and I think that those are really important findings, so that physicians really need to sit down with patients and talk about these choices. There are definite differences with these agents. I'm not necessarily convinced that one drug is best for one patient, but there are some distinguishing features. For example, the renal function I do think is important with individuals who have creatinine clearance, for example, less than 30, clearly wouldn't be candidates, I don't think, for any of these drugs. But with dabigatran, it's 80% cleared by the kidney. Rivaroxaban, I believe, is about 35%, and apixaban about 25%. So with individuals, I would think, with widely fluctuating renal function, the dabigatran may not be my first choice for that patient.
What about patients with valvular heart disease?
So a huge caveat here. This is, I would say, a contraindication that individuals with prosthetic heart valves absolutely cannot be placed on these agents. There will still be groups of individuals out there that will need warfarin, and I think for at least the next, I would imagine, 3 to 5 years, we're still going to be using warfarin for valves.
Well, thank you, Elaine. This is going to help us use these drugs more safely.